welcome to the genetics course. My name is Zuhair. I'm going to be the director of the course. The course is intended to واضح الصوت ولا ما واضح؟ واضح؟ The course is intended to be devised in a way that prepare you to be competent in genetics, not to be a geneticist. So you utilize the tools of genetics in order to help you in other specialties. The course has been there since 2009. Alhamdulillah, I'm very honored to be the director since then. And throughout the years, there is a very consistent outcome of the course, very, very striking. It is almost always, you will have almost the same percentage of students who will get A and A plus. And very similar to a percentage that will have F and fail the course. So it is very important opportunity for you. It's a very short course, one lecture per week, to get A and A plus. So try to be among those top students. The course will be mainly given by me and will be held by two colleagues, Professor Hamad Zaidan, who is our colleague in Faisal, and Professor Ahmed Hashim, who is going to come from the MAM. She will give a lecture about population genetics. She works in King Fahd Specialist Hospital in the MAM. The course has two exams. The term is 30% and the final is 70%. All MCQs. There are no short answers or essays. There is no large group discussions. It's only lectures. Very important housekeeping with respect to the attendance. We take the attendance every lecture, and be careful that this is a very short course. So if you miss a 3 or 4, then you may not be able to attend the final exam. And please don't send me any emails with respect to the attendance. The attendance is done during the lecture. Once I leave the room, the attendance is over. So please don't send me email that software didn't work, mobile was off. These excuses are not acceptable. If Allah forbid you have a problem, medical issue, you can have a medical report and submit it to the office and then certain regulations will be adopted. I'm sure that when you enroll yourself into this college, you foresee yourself in the future what your career is, whether you are going to be a cardiologist, a surgeon, obstetrician, plastic surgery, physician, etc. But genetics in your age is very different from genetics when we were medical students many years ago. Very, very different. In the past, genetics is only given as a subspecialty that is very, very boring. It covers topics like sickle cell, meiosis, Down syndrome, and that's it. And just you forgot it. And very likely that you will not be utilizing what you've learned in the first year in your career. Now this is very, very different. You will need genetics irrespective of your specialty. And you will learn this inshallah in the course. So I will start with certain scenarios just to tell you that genetics nowadays is very different from those days. So this is a mother who brings her 7-year-old child to your office because he has learning difficulties. And learning difficulties is a very common issue. And it extends from severe intellectual disability to mild learning problems, attention deficit. And in the past, the chance of detecting the variant is very low. Nowadays, if you do genetic analysis, which is indicated in many, many of these cases, you will find something. And therefore, you could be a pediatrician, a behavioral physician, a family physician, or a geneticist who deals with this common issue. A 37-year-old lady who is under treatment for breast cancer asks you if her 10-year-old daughter will be at risk of developing the same disease in the future. And you know, breast cancer is the most common cancer in females. And irrespective of the ethnicity, breast cancer is a major issue. Whether you are Asians, Latinos, Arabs, Caucasians, breast cancer is a major issue. And there are major genes involved in breast cancer. Can you give me one or two genes involved in breast cancer? I have enough. BRCA1, BRCA2. So these are very important genes. And nowadays, if you conduct genetic analysis and try to identify the variant associated with breast cancer, the lady will immediately be worried about transmitting the variant to her daughter. And especially if there is a family history of breast cancer, if her mother had breast cancer, if her grandmother had breast cancer, then the worry is very serious. So you could be an oncologist, you know oncology, which is the field that deals with cancer. You could be an oncologist, a breast surgeon, obstetrician, family physician, who deals with this very important question. A 28-year-old pregnant lady wants to know why her fetus has abnormal heart shape. And if you go across the street and you go to the nursery and you are totally blinded about the family history, the clinical condition of the babies, all what I wanted you to do is just to scan the heart of these babies. Do echo. The chance of detecting a variant, a change in the heart, is about 1%, which is very, very common, irrespective of the background of the family. So the finding of congenital heart defects could be caused by genetic factors, especially if the fetus has other abnormal features involving the kidneys, the brain, the skeleton, then the chance of detecting a genetic condition is very high. So you could be an obstetrician, a family physician, a cardiologist who deals with this genetic condition. The father of a 10-year-old boy who is diagnosed with leukemia asks you what the chance of a cure is after you started the new drug based on the result of the genetic test that you ordered earlier. You know leukemia. Leukemia is a white blood cell cancer. And in the past, many, many years ago, leukemia, the chance of a cure in leukemia in children is very poor, very low. Nowadays, alhamdulillah, it is much better. One of the reasons is that we do genetic analysis on these kids. So once you have the genetic alteration, you devise the treatment that is appropriate for this genetic alteration in order to have a better outcome. So you could be a hematologist, an oncologist, a pediatrician who deals with this genetic condition. 38-year-old gentleman asks you if he is going to develop Alzheimer's disease like his 65-year-old mother who is now bedridden. You know Alzheimer's disease. Alzheimer's is a devastating neurodegenerative disease that has been known in medicine for many, many decades. Until today, there is no cure. And the vast majority of patients with Alzheimer's disease will develop the disease at later age. And alhamdulillah, the vast majority of Alzheimer's disease patients are not affected with what we call dominant pattern. So in dominant Alzheimer's disease, the grandfather is affected, the daughter is affected, the grandson is affected. So it's vertical. And usually the presentation is much earlier. But in classic Alzheimer's disease, it's a complex genetic condition. it presents very late, so the relatives at risk, but it is not dominant disease. So you could be a neurologist or a physician in geriatric medicine. You know geriatric medicine? It's the opposite to pediatrics. So pediatrics deals with young kids or with kids, and geriatric with old age conditions. Until today, if I receive this consult in my clinic, I will not do genetic analysis in this case, because there is no intervention if you know that this individual is a carrier for this particular variant. Unless the family has the rare Alzheimer's disease form, which is the vertical one, then prevention can have an impact. You can do something for this family. The parents of two deaf girls would like to know if they can have normal children in the future. And deafness is a common disease. So if you have parents who are unaffected and two daughters who are deaf, then if you remember from the high school, the likely pattern of inheritance in this family is recessive. It's autosomal recessive. And therefore the parents will be what? Carriers. And the children are affected. So the chance of having another affected child is, what is the percentage? 25%. So the family will be very interested to know why they have this problem, and if there is a chance of preventing this in the future, instead of having another affected child with deafness. So this, you could be an ENT specialist, a pediatrician, an audiologist. You know audiology? It's a specialty that deals with hearing. Audiologist that deals with genetic condition, this genetic condition. A 45-year-old gentleman who receives insulin wonders why several members of his family have diabetes. And you don't need to be a physician in order to recognize that there are certain families who have clusters of certain diseases. And in this family, several members have diabetes. This family, several members have bronchial asthma. This family, several members have psychiatric problems. So it is, there is a genetic background in this family that makes it more likely to develop the disease. Commonly, like Alzheimer's disease, diabetes is very complex. So if it is a single patient or a couple of individuals in the family, there are no associated features, it's a classic diabetes, I will not do genetic analysis. Until today. There is no genetic analysis that can be conducted on the common variants across the globe. Here in Saudi Arabia, about a decade ago, Ministry of Health conducted a study across the nation. They wanted to know the prevalence of diabetes in our nation. The chance of developing diabetes when someone approaches 60, 65 is 1 in 3, which is very, very common. Very, very important health issue. But as I mentioned, most of the time this is a complex disease, and therefore genetic analysis is not indicated. But there is a genetic predisposition. Your neighbor was discussing with you why he had to do premarital screening. You know that we have premarital screening in this country? For which condition? For what? Which condition? What is it? Thalassemia and sickle cell. So we do since 2004. We've been doing compulsory premarital screening for thalassemia and sickle cell disease. In 2009, screening for viral illnesses was introduced for HIV, hepatitis B and C. Very recently, phase 1 expanded the screening been initiated, and we're very excited to learn about this experience. But now, the compulsory ones, sickle cell thalassemia. And why we choose these two conditions? Why did we choose these two conditions? They're common, they are severe, and they're recessive. And that's why we do this. So if you have a severe, common, and recessive condition, then this is a very important condition to be included in premarital screening. So if both couples are compatible, they call it compatible, توافق. Compatible meaning that none of them is a carrier, or at least one of them is a carrier, or one of them has a carrier. If both are carriers, then they are not compatible. They are at risk of development, of having a child with sickle cell or thalassemia. So they are going to be advised against marriage. However, there is no law to prevent this marriage from happening. So this is a genetic intervention for the population. So we are not talking about the hospital. We're not talking about the clinic. We're not talking about affected individuals. These are healthy, young individuals who wants to get married, and they have to do genetic analysis. Okay? Very, very different from our old days. Your patient who was diagnosed with a genetic disease asks you to treat this information with utmost confidentiality, as it may stigmatize his family as well as his tribe. If I am a diabetologist and I deal with the diabetic patient that I've just mentioned, the information that is going to be conveyed across the clinic encounter will be pertinent to that particular individual and only to that particular individual. And the information should not extend beyond the walls of the room because of the confidentiality. And most likely, very, very, very likely, that this information is not going to be pertinent to anyone else in the family. But if I am dealing with a deaf girl and I conduct genetic analysis and I identify the variant that is cause of genetic analysis, this information is not only pertinent to her, because her sister has the same disease. So if I test her, I find the same mutation. The parents are going to be carriers. So if I test them, the information is now pertinent to the parents, not only the child. The child may be now 20 years old. She's an adult. So this information is not pertinent to her alone, to her parents. The parents are cousins. They have a common grandfather. So this information is pertinent to the grandfather. He had the mutation. And his children, grandsons, granddaughters are at risk of inheriting the variant. So this particular variant that was conducted and found in that particular girl is now important information to so many members in the family. And the grandfather got the mutation from where? From his ancestor. And maybe very ancient variant. It belongs to the tribe. So that particular information is not only pertinent to the child or to the affected individual, to the tribe, to the region. And across the years of conducting analysis of genetic diseases, various forms of genetic diseases, throughout the Arabian Peninsula, we know the common conditions in our regions, but we cannot publish this because of the stigmatization. We keep them in our hearts. We know the common diseases that are present in Agriyat, Al-Qatif, Al-Qasim, Hayy, Najran, Jizan, Al-Taif, etc. We know. And sometimes by knowing the name of the tribe, we'll be able to say, yes, this is disease A or disease B. Because of the variant that is prevalent in that particular tribe. And this is very risky in terms of ethics, because you would be able to say, yes, this family has a gene that is responsible for blindness, intellectual disability, deafness, psychiatric illness, etc. This is very, very risky. Very different from diabetes. Very, very different. And that's why it carries its own ethical concern. And we'll address this inshallah later at the end of the course. Some of the variants that are conducted and found in our population is pertinent to Arabs outside Saudi Arabia. Why is that? Because of some of these mutations are very old, very ancient, maybe 3,000 years old or 4,000 years old. And therefore, if you have information about the history of the tribal expansions in the Arabian Peninsula, previously Arabs used to mostly stay in Yemen. And after Sad Ma'rib, the Dam of Ma'rib, collapsed, tribes expanded across the Arabian Peninsula. And after Islam, tribes expanded across North Africa, Syria, Iraq, Pakistan, India, etc. So it is not surprising to see a variant that is present in a Saudi patient, that is also present in an Arab patient in Morocco, in Iraq, in diaspora in Belgium or France, in Brazil, because originally they are from the same tribe. That's why it's very important. So we know the history. It tells you stories. Very different from diabetes. You were requested to perform identity testing using remnants of victims after a terrorist attack. And this is, if you, I'm sure that you've heard about attacks like this. So they have remnants in the scene, they collect the remnants, and then a couple of days later they post the individual who's involved. How did they do this? If with remnants or blood spots, you are capable of posting an individual and claiming that this is the one who had conducted this crime. The DNA, I extracted DNA from the blood spot and then, yes, that individual had been in the prison in the past. So nowadays, countries have their own banks for criminals. So once these people are in prison, they take their DNA, they bank them, and when there is a crime, they take the DNA and they match with their system. You remember this?
Yes.
In October last year, this famous story that happened in France, okay? In the middle of, nine o'clock in the morning. It was amazing and very crazy, very brave. They were able to break the window, got inside, got the bond, and within 7-8 minutes, everything disappeared. They got them. How did they got them? By DNA. So there were DNA remnants, maybe in the window, in the ladder, inside the museum. So they took the DNA and they matched it with their back. There are about 2 million in France, 2 million specimens that have been banked over the years for criminals. And when they matched, they said, oh yeah, we know them. So they got them. And that's why this room is full of DNA, by the way. It's full of DNA. So when you touch, you leave your remnants. So we can take DNA and we can scan that. And that's why very, very important people, when they visit, they don't leave any remnants. Any remnants, because because you cannot trace the individual by the DNA. Okay, and this is a comment in New York Times when this was happening. Private consumer genetics companies are banned in France, in good part because of the practice of tracing one's ancestry insensitive. If you've read in history, France has been involved in the Nazi and what happened to the Jews. So one of the reasons why private companies are banned from using this technology is because of this. You know this gentleman? Mendel. This is Mendel, who started all of this headache. That was in the late 19th century. And that was his publication, his experiments. And this picture, who are these? Who are these? Who are these? Watson and Crick, huh? Watson and Crick. And that's the picture they took when they described for the first time the structure of the DNA. And that was published in Nature in 1953. How many years ago? How many years ago?
73?
1953.
73?
You need a calculator. 73. More than 7 decades. Huh? We knew. And so we knew the double helix structure, but we wanted to know the exact order of these nucleotides. So the scientists in the States initiated the Human Genome Project. That was in the 1990s. And the plan was to finish in 15 years. So they divided the project between several countries because it was a huge investment, a huge undertaking between scientists in the States, several labs in the States, in Europe. And because of the advances in technology that was in parallel, they were capable of publishing the data 4 years earlier, in 2001. And it was a very important scientific landmark in the history of medicine. Very, very important. It was announced in the White House by the president then. And it was the first scientific announcement ever in the White House. And published in Nature as the first draft of the human genome. And the completion was announced in 2003, 2 years later. So they finished the project. So how many years it took us from the description of the DNA structure until we knew the exact order? 50 years, half a century. And the project lasted for 13 years. It cost about $3 billion, mainly funded by the US government. Nowadays, in this room, you can utilize your mobile, go to one of these private labs that offer genome analysis, and pay with your credit card about maybe 3,000, 4,000 reals instead of $3 billion. And next day, a kit will be next to your door. You spit, you leave your trace, your DNA there, you ship it. 3-4 weeks, your whole genome is in your email. It's amazing. And that's why the prediction is that in 2030, the cost will be around $100. So it is going to be very affordable. Very risky. Very, very risky. It has its own ethical concerns. So overutilization of this is very risky. And this is a description of the tremendous changes that we had seen over the past decade. The cost declined and expected to go down further. The discoveries of new diseases. We are now having about 7,000, so it is expected that we will learn about 1,000 10,000 genetic conditions. And as a result of this, you will have a new treatment available to incurable conditions. FDA approved. FDA stands for what?
something.
FDA is the agent and الغذاء والدواء, Food and Drug Agency. This is in the States. This is the agency that is in charge of approving new medicines. If I'm a researcher, I'm interested in diabetes, I wanted to develop a new disease, I do my experiment, and after the experiment, I found that the medication is very successful, I submit my requisition to FDA. So they review my results, my publications, and they say, yes, your intervention is very successful, you got the approval. So this is the FDA. We have here FDA, it is the Saudi FDA, it's FDA, Saudi FDA. This is a projected annual storage that is required if you would like to have the data for individuals. So if you are interested in astronomy, you know astronomy, that's the projection. If you are in charge of Twitter or X, that's a projection, annual projection, requirement of IT support and storage. YouTube, and that's genomics. Massive, massive. So the massive information that we get from a single individual, if you do whole genome analysis, is huge. So we need an infrastructure that can help us to understand this huge information. And the knowledge is there, but we don't know what to do with this knowledge. So we need this infrastructure that is very important. If you go across the street and you go to the pediatrics floor, you will see almost half of the cases that are admitted there are due to monogenic diseases. Sickle cell, thalassemia, cystic fibrosis, etc. And monogenic diseases are diseases that are caused by changes in single gene, like sickle cell or cystic fibrosis. You can do genetic testing for diagnosis, like deafness. If the deaf girl would like to know why she has this, we can do genetic analysis to diagnose her genetic condition. Or carrier detection, you can check the parents, detect their carrier status. Or population screening programs, like the premarital screening that we have. Or newborn screening. Newborn screening, like, give me a condition. Do we have a newborn screening in this country? Yes? Which condition? Hypothyroidism, congenital hypothyroidism, and okay, some history. In the 1960s, in the States, they began screening newborns for a condition that's called PKU, phenylketonuria. And phenylketonuria is a biochemical disorder that is secondary to deficiency of phenylalanine hydroxylase. So phenylalanine is converted to tyrosine by this enzyme. If there is a block, phenylalanine will be high. If I scan this room, the chance of finding the level of phenylalanine should be around 100 micromolar, plus minus. But if these babies have this condition, severe phenotype, and I check their phenylalanine will be in 1,000. This is very, very neurotoxic. And therefore, it is an emergency. Whenever you detect this, it should be done on the second, third day of life. You manage early, you can overcome the issue. I have a girl who is a factor of PKU. She was diagnosed in the neonatal period. She has been always the first in her class. Whereas if you miss the case, every month you lose 4 IQ points. So by the age of 6 months, you are in the range of severe intellectual disabilities. Severe. Even if you start the treatment at the age of 3 months, you will have significant drop in the IQ. You will not be a competent student. if you leave these babies without treatment for 3-4 months. And I have another student who has PKU. She's capable of memorizing the whole Quran. So you see the difference. Early intervention makes a huge impact in terms of health. If you miss this opportunity, the case is done. So we have PKU. As a pilot, we started screening in the 90s. Officially, we started screening newborns in 2005. We screened so many conditions, including deafness, including congenital heart disease. Predictive testing like what? Yalla, predictive testing like the breast cancer. You can predict that this 11-year-old daughter is going to develop breast cancer or not. Susceptibility testing like Alzheimer. Your genetic background makes you more susceptible to develop Alzheimer's disease. Prenatal diagnosis. You can take a sample from the chorionic villus or amniotic fluid to understand if the fetus has the same disease like a sibling, for example, the deafness. And what is this? What is this? Pre-implantation genetic diagnosis? Utilizing IVF. So if the family with deafness wanted to have another child, you can utilize this technique. So in the lab, you utilize IVF, in vitro fertilization. The zygote is formed in the lab. You have 8-cell stage. You take one cell, you extract the DNA, and you subject it for the same analysis that was conducted to identify the mutation. So if this embryo has the variant, he or she will develop the deafness. If she doesn't have the variant, you can implant it in the uterus and pregnancy continues normal. That's the monogenic diseases. Now, and we will address this further in the course. The common diseases are interactions between environment and genes. And examples, as I mentioned earlier, diabetes, Alzheimer, bronchial asthma, psychiatric illness, etc. One of the very good examples of genetic associations is the genetic associations in relation to development of atherosclerosis. Science is producing, should be producing. If I conduct an experiment in my lab and I claim that this particular experiment will end up having this particular result, and I publish it, and you conduct the same experiment in your lab using the same conditions, you should get the same result. Otherwise, there is a problem in my experiment. Either I'm lying, I'm fabricating, or I have a problem with my experiment. So science is reproducible. This is a very similar work. 3 independent studies, independent. They conducted genome analysis, blind analysis, a huge cohort with heart disease, a huge cohort with no heart disease. And they identified the same conclusion. We have a problem with chromosome 9. There is something on chromosome 9, a change in the DNA, that makes us more to develop heart disease. Likewise, in asthma, in HIV, this change in the gene makes someone resistant to develop AIDS if HIV got there in the system. These are some of the genes. You don't need to remember the genes and the numbers. It's just to give you an idea that these common diseases are associated with certain conditions and make someone more prone to develop these conditions if there are certain changes. And you remember COVID. Well, you were too young. You remember COVID. You have the same virus. An individual is very severely affected in the ICU, and the other one is asymptomatic. And you have the same virus, the same vaccine. You give it to someone, is protected. Another one, he got every now and then infected with the same vaccine. But we are different. We have genetic backgrounds that are very different from each other. And therefore our interactions to viruses, environmental factors, and vaccines are very different. So one size fits all, which has been the same marketing tool that has been utilized by companies, pharmaceutical companies, is no longer going to be the case. You have headache, took 2 tablets Panadol. But we know that Panadol does not work all the time. Because we have 2 different genetic backgrounds. Maybe effective in one, ineffective in the other. Or maybe effective in one and toxic in the other. And we know this, inshallah, in the future in your practice. You give the same medication to 3 individuals. One works, the other one doesn't work, the third one develops side effects. You have to stop the medication. So one size fits all is no longer going to be the case in your practice. You're going to have precision medicine. You do genetic analysis, you do precision medicine analysis, and then you devise the approach. And we have new tools, new vaccines, new drugs, stem cell therapy, CRISPR. You know CRISPR? It's like if you submit an article to a newspaper, there is someone who is called an editor. So he erases certain words and puts other words. CRISPR does the same thing. You submit a gene with a mutation, and the CRISPR technique will erase this variant and puts the right nucleotide. So it corrects. It's very powerful, very cheap, very affordable. And because of this, those who invented the techniques, or discovered, I should say, those who discovered the techniques got Nobel Prize. 2 young ladies. Very, very surprising in medicine. Usually, Nobel Prize give people who are old. Like you had 2 young ladies because of this very powerful. And people say that science and medicine will change in the future by 2 things: AI and CRISPR. You will see this, inshallah, in the future when you practice. But it's not only genetics. Diet is very important, smoking, lifestyle. And I will end up by this case that was written by Francis Collins. Francis Collins was the chairman of the Human Genome Project. And then he was the chairman of NIH. You know NIH? National Institutes of Health. He was a very famous guy during the COVID-19. Because NIH was involved heavily in preventive tools. Anyhow, he was very excited almost at the end of the project. That khas, we know everything. We know the genes involved in common diseases. We are going to prevent this from happening. Medicine is going to change. And he published this in 1999. How many years ago? Yalla al-hasba. How many years ago? Huh? 27 years ago. Until today, 27 years later, we cannot conduct this. We cannot conduct this. So he gave this case, hypothetical case, a 23-year-old young man who wanted to know his future risk for developing diseases. So he did genome analysis, and he found that he is at lower risk of developing Alzheimer's, prostate cancer, but he was at high risk of developing heart disease and lung cancer. If he would look at the risk 6 times. So if he is a smoker, and you tell him that you are at 6 times risk of developing lung cancer. So this is very important information for him to quit smoking. That's type. Now suppose that after genome analysis, this is here. So he may perceive that he is now protected against lung cancer. He may smoke heavier and heavier, and he will develop lung cancer. So that's why until today, 27 years later, we don't conduct this. Because there is no major medical intervention that can be done for these individuals. The Alzheimer, well, prostate cancer, well, lung cancer. Knowledge without intervention. No? And that's why there is no need to make people worried about their future. And to go after after 50 years you'll develop Alzheimer's disease. So what? And give me something that I can help myself to prevent it. Otherwise, don't tell me. صح ولا لا? It's a futility. طيب, we know about this. I've already mentioned about this table, the cost and the discoveries of genetic diseases. Make sure that you learn about genetics after the course, across the years, because you will see so many advances. It will invade, and it is already invading subspecialties, across subspecialties. So make sure that you learn this. And as I mentioned, that you can utilize your mobile phone to conduct genome analysis. So it continues across the postgraduate years. I left in the syllabus, at the end of the syllabus, the resources. Thompson textbook is very important. The slides, and there are websites. We have our own jargons, our own language. You will be faced with so many terms. And if you have problems, just go to these resources and it will help you, inshallah. Your attendance. Any questions?
أنا بس قلت كلمة لا حتى يا رب ما يطلع مكلم